Hi, this is Brian Kim. I'm going to share with you this case of a patient with Fuchs dystrophy as well as a visually significant cataract. This patient opted not to have a corneal transplant at the same time, so we're going to do as gentle as possible mechanical fracturing techniques to maximally protect the corneal endothelium. You'll see that the CDE is very low and all the maneuvers are going to be at the iris plane or below. And utilizing mechanical fracturing minimizes fluidics as well as ultrasonic energy, and you'll have clearer corneas. So you can see that there's quite a bit of gutata, about 3 plus, and it does affect the view just a little bit. You can see the speckling on the corneal surface. I'm going to use a cotton tip to hold the eye steady and then use a corneal mark to help me center and size my rhexis. I make my paracentesis incisions, making sure I'm parallel and flat to the iris plane. On two sides, I'm using the cotton tip for support. This allows you to create a nice corneal shelf, and this will definitely allow you to have a self-sealing corneal incision. I'm going to inject intracameral epinephrine and then dispersive viscoelastic. It's important to use a nice dispersive viscoelastic to coat and protect the corneal endothelium. Once the eye is filled, I'm going to use the cannula to hold the eye for my triplanar corneal incision. I'm going to make a vertical groove, place the blade into the groove, and I'm going to tunnel through the cornea and then dimple down and then enter, and this is a triplanar corneal incision. I'm going to enter the incision with my rhexis forceps, and I'm going to do a puncture style technique. I'm going to first puncture the center, pull downward towards me, and pulling a little bit towards the right so that I can get a nice little flap here. I'm going to gently re-grab as I go. And I want to make sure I get a really nice rhexis. You want to get a nice rhexis so you can get good overlap of the optic, 360 degrees. So I'm taking my time going around circumferentially, and I'm re-grabbing as I go, following the corneal mark initially that I made, which will help me to center and size the rhexis very nicely. With this dispersive viscoelastic, it's very good to have frequent regrabs, because if you don't, this viscoelastic in particular tends to run out a little bit. So I'm grabbing and re-grabbing as I go, and you can see this is a very nice centered and sized rhexis. I burp the viscoelastic out of the eye, and we're going to begin the triplanar corneal incision. I'm going to go in with a cannula flat underneath the contralateral anterior capsulorhexis edge out to the capsulorhexis, point it down, and then push, and you get a nice fluid wave. I'm going to decompress on the left side. You can see it decompress nicely. And then I'm going to the right side, decompressing, and then pointing it downward, and then I begin to start to turn the lens. By pointing it down, it does increase my leverage to be able to spin the lens, which occurs quite nicely. I then do the phaco, lift the incision with the chopper, go in with the phaco tip with irrigation off, and then I'm going to activate my fluidics and try to remove the surface epinuclear material. By doing this, I'm able to create an epinuclear ridge, so I can place my chopper out to the contralateral equator underneath the anterior capsulorhexis edge, turn the phaco tip vertically, subincisionally, crush the lens by bringing both instruments to the center, going out to the contralateral equator on the right side with the chopper, pulling it centrally towards the phaco tip, and then crushing the right heminucleus. So that is the double chop and cross chop. I lift up the first quadrant out of the bag with the vacuum and start mechanical fracturing that first quadrant, crushing the lens between the chopper and the phaco tip. And then once the pieces are small enough, using that high vacuum to help evacuate that lens piece. I place the chopper out to the contralateral equator again, and then pull the chopper centrally to crush that second quadrant in half again. You can see the movements are very gentle, very slow and methodical. Once the pieces are small enough, I'm leveraging that high vacuum that I can use on this machine that will help evacuate and emulsify the lens pieces. I pull the lens piece out of the bag with the chopper, and then I begin crushing the lens piece and then using the high vacuum to remove the lens piece. You can see here I'm getting a little bit of fluid to my paracentesis, so I use a chopper and I just kind of pull the conjunctiva away, and this helps to prevent that ballooning of the conjunctiva during the phaco. Now that two quadrants are out, I'm going to rotate the second heminucleus in front of me very carefully. I place a chopper out underneath the anterior capsule to the capsulorhexis, and then I bring both instruments together, crushing the lens in half, and then I grab the third quadrant, crushing it and dividing it using mechanical fracturing forces to crush the lens piece between the chopper and the phaco tip. I still get some fluid here, so I went ahead and came out with the chopper, pulling that conjunctiva down. I'm attacking the fourth quadrant, placing the chopper out to the equator, bringing both instruments together, crushing that fourth quadrant in half, and then using mechanical fracturing forces to crush the lens pieces into smaller pieces, and then using high vacuum to remove the lens pieces. You can see the CDE is quite low, and I'm intentionally using less ultrasonic energy and using more mechanical fracturing to evacuate the lens pieces. Once the endonucleus is removed, I begin to focus on removing the epinuclear material, and this is purely a vacuum technique here. I'm grabbing the anterior edge of the epinucleus, and you can see the epinucleus tumbles out quite nicely. I always keep the chopper deep in the bag whenever I am doing phaco, especially when I'm working on the last quadrant as well as the epinuclear step. Once the lens is completely out, I take the chopper out, push BSS with the cannula, take the phaco tip out, and then replace it with the INA handpiece. And I do this to help maintain the chamber. You can see I'm using the cannula to help tease the conjunctiva away from the paracentesis incision to help minimize that conjunctival ballooning. I start subincisionally with the cortical removal, and then I start working my way around circumferentially. Due to the very high vacuum and control I have, as well as the polymer tip, INA of the cortical material has really become very routine in my hands. And so I'm going to start polishing now. You can see there's quite a bit of lens epithelial cells underneath the anterior capsulorhexis edge, and as well as some on the posterior capsular surface. It's not as obvious on the video on the posterior capsule surface, but there is very visible anterior capsule lens epithelial cells. You can see I'm going around polishing, using that nice polymer tip to polish around circumferentially. Once I'm done polishing, I'm going to go in with the BSS cannula and go into the subincisional capsular fornix and just start to pulse some BSS in that space. There was not much cortical material there, so then I switched to a cohesive viscoelastic cannula, filling the capsular bag with the cohesive viscoelastic, and then I use the capsular sweep now to sweep on the left side first, making sure I'm going around. This patient's right eye has a little bit of a Bell's reflex, and the eye wants to turn upward, which is towards the left. So I used my cannula to hold the eye while I swept the left side. As I continue to sweep here, you can see there's quite a bit of nice cleanup of the lens epithelial cells. Now I switch to the other side. This patient's now looking downward, but I ask her to look up, and then she's able to do so, and I'm begin to start polishing on the right side now. You can see there's nice removal of those lens epithelial cells with this capsule sweep. Then widen the incision with my blade because this is a 3-piece intraocular lens. I'm going to inject the intraocular lens bevel down, and then I'm going to turn the bevel to the left. As I deliver the lens, the leading haptic comes out planar underneath the anterior capsule towards the left, and as the optic is delivered, I'm rotating the barrel counterclockwise so the optic comes out flat, and then you leave the trailing haptic out of the eye. And then we use a Maltzman instrument to push the optic haptic junction in, and this dials the lens into the bag as well as the trailing haptic. There's a little bit of reverse pupillary block, and as a result, when I place the INA handpiece in, I first release that pressure by lifting up the iris on the left side, and then I go underneath the lens here, tilting it, making sure I remove all the viscoelastic from within the capsular bag and underneath the lens. And then I go up and then go in front, removing the viscoelastic in the anterior chamber. Again, I use dispersive viscoelastic. You want to be very careful removing all that viscoelastic coating the corneal endothelium. Here I'm polishing underneath the anterior capsulorhexis edge to remove any more potential lens epithelial cells that are there. And you can see a very nice overlap of the capsule with the optic. I'm polishing and taking my time, making sure it's a very nice, clean bag, making sure there's no remnants of lens epithelial cells or cortical material within the bag, and then remove the viscoelastic from the anterior chamber, making sure that the viscoelastic is out of the angles as well as off of the corneal endothelium. Before I take the INA handpiece out, I push BSS into the eye and pushing more into the angle, make sure there's no viscoelastic. And then I pull the INA handpiece out, I push BSS, and then quickly hydrate my incisions, and that's the end of the case. So as you can see, this is a patient with Fuchs dystrophy. She had 3+ corneal guttata, and you can see that in the view during the surgery. However, the patient did not have any significant corneal edema, and so she decided to have cataract surgery without a corneal transplant. Because she may have to have a future corneal transplantation, I always choose to leave these patients slightly nearsighted to take into account for the corneal tissue. I also prefer a 3-piece intraocular lens in these cases because as I go in with the tissue, it can cause the chamber to collapse, and I feel like the 3-piece lens provides more capsular support. And she saw mechanical fracturing techniques, which help to minimize ultrasonic energy and protect the corneal endothelium. And so in my mind, mechanical fracturing, double chop and cross chop, using a minimal amount of fluidics and ultrasonic energy, using mechanical fracturing forces to crush the lens pieces into small enough pieces and just evacuating them with high vacuum is the best and most gentle way to do cataract surgery on the compromised cornea. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.